Greetings of the day, everyone, whichever part of the world you are in. Welcome to the Radiology International Lecture Series organized by Global Association of Physicians of Indian Origin, GAPU. GAPU is a non-profit organization with a mission and vision of bringing together 1.4 million physicians of Indian origin on one professional platform. DocPlexus is the digital outreach partner for the session today, and this event is also available on the YouTube channel of GAPU. For those of you who are joining us for the first time today, I'm Dr. Vinita Sharan. I'm the CME advisor for radiology for GAPU. I am a senior radiology consultant at Deep Tech Medical Services Private Limited. I read mostly musculoskeletal and spine MRIs, and I'm also your moderator for today. This is our fifth webinar for this year, and the topic, comprehensive imaging of pancreas, advancements and role of AI, is of great significance. Pancreas is a vital abdominal organ, and it regulates our glucose metabolism and also affects our gastrointestinal or the digestive system. The commonly used modalities are ultrasound, CT scan, and MRI. Other modalities like PET CT scan are done as indicated. Since the only thing that is constant in this world is change, so a lot of advancements has taken place in the imaging protocol for imaging of the pancreas. Artificial intelligence is also being used to assist in the diagnosis of pancreatic diseases. It is always helpful to remain updated. Today we have Dr. Lieutenant Colonel Priscilla Joshi, who will educate us on the fundamentals of pancreatic imaging, and Dr. Avinash Kambadikon to discuss the advancements and use of artificial intelligence in pancreatic imaging. After the two talks, we will have a short question and answer segment, for which may I request the audience to put your questions in the or your queries in the chat box below. And moving ahead, I would introduce our chairperson for this evening, Dr. Anil Arora. He is unfortunately delayed and he would be joining us soon. So let me introduce Dr. Arora. He is a senior consultant and chairman, Institute of Liver Gastroenterology and Pancreatico-Biliary Sciences, Sir Ganga Ram Hospital, New Delhi. He started the liver transplantation program in 1999 at Sir Ganga Ram Hospital, New Delhi. Dr. Anil has been involved in various clinical and as trials as principal investigator or co-investigator. Dr. Anil is founder member of Delhi Liver Foundation Trust and past president of Indian National Association for Study of Liver. Dr. Anil has organized various free health camps and public awareness programs for gastrointestinal and liver diseases. He has been conferred with many awards, including Delhi Ratan Award, Distinguished Gastroenterologist Award, Legends in Gastroenterology Award, Dronacharya Award for his exemplary work in the field of gastroenterology and liver transplant. And he also has an interest in hepatology, viral hepatitis, cirrhosis of liver, liver transplantation, therapeutic endoscopy, and stem cell therapy in liver and pancreatic diseases. So he will be joining us later, and he will also give us some information on the so from the surgical and treatment perspective, the role of imaging. He will be talking about that. So moving ahead, I would like to introduce our first speaker for the evening, uh, Dr. Lieutenant Colonel Priscilla Joshi. She is a professor and head of Bharati Vidyapeeth University Medical College and Hospital and vice principal PG Academics. Dr. Priscilla has served as a graded and classified specialist in the Army Medical Corps, and her special interest is in pediatric radiology. She is the recipient of Dr. M. V. K. Shetty Oration ISPR 2017 and Best Teacher Award, Bharati Vidyapeeth University in 2017. Dr. Priscilla has published 9 book chapters and gave over 100 presentations. She is reviewer of BJR, IJRI, Pediatric Radiology, and Curious. Dr. Priscilla, may I request you to start your talk?
Thank you, Dr. Vinita, for the kind introduction. And at the outset, I'd like to thank Gapio for inviting me to deliver this talk. Greetings from Pune, India, for those who are abroad. And so I'm going to speak to you on imaging of the pancreas, the fundamentals. As we all know, the pancreas has always challenged radiologists, not because of its deep retroperitoneal location, but also because of the wide spectrum of diseases which affect it. These often have overlapping clinical and imaging features, and it is up to us as radiologists to try and differentiate one condition from the other. With modern cross-sectional imaging, our ability to visualize the pancreas in exquisite detail has transformed patient care, guiding everything from early diagnosis, surgical planning, long-term follow-up. Today, I'll be taking you through the fundamentals of pancreatic imaging. We'll begin with the normal anatomy, the strengths of different modalities, and move on to major disease processes. And this is how we'll go about it. So we'll talk a little bit about embryology, imaging anatomy, the right first test and protocol, recognize imaging patterns in pancreatic diseases, a reporting template, especially for acute pancreatitis, limitations, and take home. So this is what the pancreas looks like in a diagrammatic representation. You can see that it's a retroperitoneal structure just anterior to the IVC and the aorta, nestled within the C loop of the duodenum. There are multiple important structures surrounding it, which include the CBD, which joins up with the pancreatic duct to enter the second part of duodenum at the ampulla of Vater. You also have multiple important vessels, the pancreaticoduodenal vessels, the dorsal pancreatic artery. The pancreas is draped over the splenoportal axis, as I would be showing you shortly. And all these structures are very, very important, and we need to image all of these. Now, the pancreas consists of the uncinate process, the head, neck, and body. And it's important to visualize each and every one of these parts of the pancreas. How does the pancreas develop? In the 5th week of gestation, you have ventral and dorsal outgrowths of the primitive foregut. And as the duodenum distends or it enlarges, these ventral bud which is there, that moves in a clockwise direction and goes towards the dorsal pancreatic bud. And then both these fuse. The ventral bud forms the posterior part of the head and the uncinate process, whereas the dorsal bud forms the anterior part of the head, body, and tail of pancreas. The main pancreatic duct, that is the duct of Wirsung, is the ventral duct and the distal portion of the dorsal duct. So that is the duct of Wirsung, which is the main pancreatic duct. And the accessory duct is the duct of Santorini, which may be present. It is the persistence of the proximal portion of the dorsal pancreatic duct. The minor papillae downstream to the dorsal ventral fusion point. The ventral pancreatic duct and the CBD are linked by an embryonic origin. So here you can see that's the CBD there. That's the ventral duct, and that's the dorsal pancreatic duct, which is draining the body and the tail. And whereas the part which is more distal is drains into the minor papilla. And this is the accessory duct of Santorini, which may be present. So it's important to be familiar with this anatomy. Why does imaging matter? Because there are certain pathologies affecting the pancreas, like congenital anomalies, annular pancreas, pancreas divisum, inflammation, pancreatitis. We all know that it's got a very high index of mortality, or high incidence of mortality and morbidity, tumors, trauma. The post-operative pancreas, I won't be covering this for paucity of time. So the imaging armamentarium we have available with us include radiographs, plain radiographs, ultrasound, CT, MRI, PET CT, and endoscopic ultrasound. Plain radiographs now are rarely used. They are of historical significance to some extent, but sometimes they are done. And in that case, we need to look for any radiodensities overlying the L1 vertebral body. And if these are more caudally placed on the right and more cranially placed on the left, that means they're obliquely placed like this, you should think of pancreatic calcification. And of course, the pancreatic calcification is far better seen on CT than it would be seen on a plain radiograph. And here, of course, you have a case where you're seeing extensive pancreatic calcification, got the classical feathery pattern of the pancreas. Earlier, there used to be multiple signs which were there for diagnosing acute pancreatitis, like the sentinel sign, the colon cutoff sign, but these are now almost historical, and we rarely ever get to do radiographs and see these conditions. Ultrasound is usually the first modality used because it's easily available, cheap, can be done at the bedside, and is good as a screening tool. Of course, there is no radiation associated with it. However, certain drawbacks are there, and obese patients, it may be difficult to see the pancreas. If there is a gaseous distension of bowel loops, which invariably is there, it may be difficult to see the pancreas. It's operator dependent to some extent, may not pick up all the findings, and the tail sometimes may be difficult to visualize. So how do you scan right? So here you follow the piece. This was taught to us long, long ago. Patience. Put your transducer there and try to dispel the overlying bowel and try and see the pancreas. Pani, give the patient water to drink, distend the stomach and use this as a window to see the pancreas. Position, you can make the patient slightly recumbent, make the patient sit up a little rather, and try and see the pancreas. And tell the patient to distend the abdomen, pet pull out, bloat out the tummy, and try and see the pancreas. And this is how you see the pancreas. That's the portal vein, that's the splenic vein over there draining into the portal vein. And this hypoechoic tissue, which is there draped around the splenoportal axis, is the pancreas. Again, you can see it very well over here. That's the SMA, that's the SMB. So this is more inferior or caudal to the section over here. On the longitudinal section, that's the left lobe of liver, and you can see part of the pancreas, posterior and caudal to it. That's the IVC, aorta, SMA, and that's the portal vein and the splenic vein. So you can see there are very, very important structures here, and you should be familiar with this anatomy. The pancreas appears homogeneous, of course, and is almost the same echogenicity as the liver. As age advances, the pancreas gets replaced by fat and becomes more and more echogenic, and the size also starts shrinking. This is a blown up image to show you the head, body, and tail of the pancreas. That's the portal vein, splenic vein, the superior mesenteric artery. Posteriorly, you have the vertebral body. And this is the left lobe of liver, which you're seeing anterior to the pancreas. So the role of ultrasound is to evaluate the pancreas, its size, appearance, any presence of any calcification or calculi, duct dilatation, if there is any edema present, if there are focal lesions, if there's any walled off necrosis, or there is presence of pseudocysts. Simultaneously, it's important to also evaluate the gallbladder because presence of calculi can give you an indication as to the cause of pancreatitis, to evaluate the CBD to see if there is any CBD dilatation or if there are any CBD calculi. And indirect signs of pancreatitis, sometimes you may not be able to visualize the pancreas, in which case you should look for indirect signs like presence of exudates in the pararenal fascia, paracolic gutter, presence of fasciitis. Look at the vessels, the splenoportal axis, for any evidence of thrombosis, for presence of pseudoaneurysms. These are all complications of pancreatitis. Evaluate the spleen, whether it's normal in size or enlarged, and if there are any focal hypoechoic areas suggestive of infarcts in case there is a splenic or a portal vein thrombosis. Also look for left pleural effusion, which is again an indirect sign of pancreatitis. CT is the backbone of pancreatic imaging. It's an excellent modality for evaluating the pancreas, peripancreatic fat stranding, other complications. Contrast administration is mandatory with multi-phase enhanced imaging. It's optimal for identifying and characterizing pancreatic masses, complications from pancreatitis because of shorter acquisition times and better patient compliance. However, only radiopaque calculi in the gallbladder and CBD will be picked up. The CBD and pancreatic duct are better evaluated on MRCP. Radiation is associated with CT. Cost, availability, and contrast administration are the other drawbacks. So multi-phase CT protocols usually include an unenhanced scan followed by a pancreatic phase, which is a late arterial phase, and the portal venous phases. So that's a plain scan. You can see the pancreas over here, uh, like you were seeing it on this diagrammatic representation which I showed you. That's the C-shaped structure, which is here, or a comma-shaped structure. This is the arterial phase. That's the portal vein, splenic vein. And you can see that's part of probably the hepatic artery there. That's the portal splenic vein. That's the aorta. That's the IVC. That's the pancreas. Please look at the peripancreatic fat, and it should be jet black fat. In case there is any haziness of the mesenteric fat surrounding the pancreas or the peripancreatic fat, that should give you a clue as to there is something wrong, or there could be a early acute pancreatitis. Again, you can see the duodenum over here, which is very close to the head of the pancreas. On CT, these are more images to show you the splenoportal axis, the splenic vein, IVC aorta, stomach, and that's the stomach over here. That's the duodenum which you're seeing, and the C loop will come here. In this region, you also see the CBD, and you see the pancreatic duct at times, depending on the age of the patient. Now, there are certain measurements which are there for the head, body, and tail. Anything more than 3 centimeters for the head is abnormal. For the body, 2.5 centimeters, and 2 centimeters for the tail. And these are the areas where it is taken: the head, the body, that's the neck there, and that's the tail. The normal pancreatic duct measurements vary by age and region, and they should be less than 3 millimeters in the head, 2 millimeters in the body, and 1 millimeter in the tail. What is the CT protocol we use? It's a helical CT, obviously, which we do now. You can even do dual energy, but I think the speaker following me would speak about it, since he's talking about advances. The section thickness is sub-millimeter. Your oral contrast should be a neutral oral contrast. We give water and mannitol at our center. We give high iodine concentration. IV contrast, we normally use either 350 or 400 milligram of iodine per ml, with an injection rate of 3 to 5 ml per second. A pancreatic parenchymal phase of 35 to 40 seconds is used, and a portal venous phase of 60 to 70 seconds. If you're suspecting a neuroendocrine tumor, you need to do an early arterial phase, otherwise you might miss the tumor. Image reconstruction is done at 2 to 5 ml thickness. You can do multiplanar maximum intensity projection and volume rendering. While reporting a CT scan, it's important to report the appearance in the of the lesion, if there is a focal lesion, or if there is no lesion, or if it's a pancreatitis, the appearance in the pancreatic parenchymal phase, the size, the location, if there is any involvement of the pancreatic duct, if there is any dilatation of the duct, biliary duct, the biliary tree, extrapancreatic disease, venous or arterial involvement, and morphological evaluation. MR is the other modality. The big advantage of MR is no radiation is there. However, the scan times are longer and patient compliance is relatively less, especially breath holds, if the patient is unwell. Pancreatic duct anatomy is much better seen on MR than on CT. The gallbladder and CBD are well seen and assessed. You can even see radiolucent calculi. And study without contrast also gives you information required in patients who have renal impairment. So it's a good investigation to do. Cost and availability is the other problem or a drawback. Now that's the pancreas over here, which you're seeing, the comma-shaped organ, which you're seeing in the retroperitoneum. And that again is the pancreas. That's a T2-weighted axial sequence, and that's a stir or a spare or a fat suppressed, T2 fat suppressed sequence where you're seeing the pancreas. So whatever fat is there within the pancreas is getting suppressed. So MR is beneficial for characterizing cystic lesions and characterizing and even identifying some solid tumors, especially the smaller ones. The other sequences done are diffusion weighted imaging for small. It can pick up small tumors. You can do T1 weighted, which the T1 fat, if it gets suppressed or if it becomes hypointense, you should think of early pancreatitis. So these are T1 weighted images, which are showing you a bright pancreas over here. These are in phase and out of phase images. And this is a post-contrast T1 weighted image. You can do a dynamic post-contrast T1 weighted image, which is fat suppressed, and look for any focal lesion within the pancreas. MRCP is the other investigation done on MR, and this is a heavily T2 weighted image, which is done for evaluating the biliary tree as well as the pancreatic anatomy. And here you can beautifully see the pancreatic duct, which is there. You can see the CBD there, and that's the ampulla of Vater. And you can see that both the pancreatic duct and the CBD are draining over here. And here you're seeing the minor papilla with the drainage over there. So that's the normal anatomy. Now, MRCP has a disadvantage that you need a good breath hold, though now there are free breathing techniques of MRCP also available with some of the vendors, but it still is a problem to acquire these images sometimes, and especially in patients who have ascites, it becomes a big problem. PET-CT plays a role, especially in neoplastic lesions. This was an 18-year-old female with nausea, vomiting, loose motions. Ultrasound found a mass extending from the epigastrium to the left hypochondrium. And this was the solid mass which was there. They were looking for an occult primary. And this lesion had an SUV of about 3.6. And this turned out to be a solid pseudopapillary neoplasm. This patient underwent a distal pancreatectomy and splenectomy. Endoscopic ultrasound plays a role when there are small pancreatic tumors, especially tumors like insulinomas or neuroendocrine tumors, when you need to first locate the tumor as well as biopsy the tumor. So this is what an endoscopic ultrasound would look like, and that's the lesion over there, which can even be biopsied on endoscopic ultrasound. So now let's go through a few cases. So congenital anomalies, one of the most common congenital anomaly is the pancreas divisum, which occurs in 4 to 10% of the population. It occurs because of failure of the dorsal and ventral pancreatic buds to fuse during the 6 to 8 weeks of gestation. The pancreatic head and the uncinate process are drained by the duct of Wirsung through the major papilla. The body and tail of the pancreas are drained by the duct of Santorini through the minor papilla. Now, most of these patients are asymptomatic, but some have recurrent episodes of pancreatitis. And these are the ones who come to you for evaluation and to rule out any anomaly. And it is postulated that the duct of Santorini and the minor papilla are too small to adequately drain the pancreatic secretions produced by the pancreatic body and tail. And this is one such case over here. You can see that's the CBD, and that's the main duct which is here, which is draining here, and that's the duct of Santorini, which is now draining the entire body and tail of pancreas as well. And this minor papilla is too small to take this amount of pancreatic fluid draining into it, and that is why these patients sometimes land up with problems. So you see a prominent dorsal duct draining through the minor papilla and the smaller ventral duct draining through the major papilla, as you can see in this diagrammatic representation as well. And that was a normal MRCP for comparison to show you that this is how it should be. That should be the entire pancreas, except for a small bit draining into the major papilla and the small bit draining into the minor papilla. Annular pancreas occurs due to abnormal periduodenal migration of the ventral pancreas, and it appears like the pancreas is completely encircling the duodenum, and it causes a narrowing of the duodenum. Differential diagnosis would be conditions such as duodenal stenosis or duodenal atresia or duodenal webs. And this is what the pancreatic duct would look like because it is encircling the duodenum in this particular case. How would you see it on CT? This was a patient who was a case of CS stomach who had been operated, undergone a gastrojejunostomy and come for follow-up. And this patient had multiple hepatic metastases. In addition to that, you were seeing a mass-like lesion in the head of pancreas, which when you looked at it carefully was actually an annular pancreas. So if we play this again, you will see this particular thing. So as we go down, if you continue to follow the pancreas, you would see that you're seeing this lesion over here, which is actually an annular pancreas. This is an annular pancreas, which is surrounding the duodenum, and you are seeing it surrounding the duodenum. So this is also known as the crocodile jaw pancreas because of failure of the ventral bud to rotate with the duodenum, causing encasement of the duodenum either completely or incompletely. It can cause duodenal obstruction. Like we saw, the pancreatic tissue completely or incompletely surrounds the duodenum. There is duodenal narrowing, dilatation of the proximal duodenum. On MRCP, you can see the pancreatic ductal anomaly. Pancreatitis is something very important. When you're looking at pancreatic imaging, it's an acute inflammation of the pancreas, which is potentially life-threatening. For diagnosis, you need 2 of the 3 criteria, which is acute onset of persistent severe epigastric pain, elevated lipase or amylase to 3 times, and characteristic imaging features on contrast-enhanced CT, MR, or ultrasound. There is a revised Atlanta classification. I think we're all familiar with it. I won't go into it, but you're basically dividing pancreatitis into interstitial edematous pancreatitis and necrotizing pancreatitis. And before 4 weeks, you see acute pancreatic fluid collections in edematous pancreatitis. After 4 weeks, pseudocysts in necrotizing acute necrotic collections before 4 weeks, and after 4 weeks, walled off necrosis. This may be either sterile or complicated or infected. On ultrasound, you see an increased pancreatic volume with marked decrease in echogenicity. The pancreas appears hypoechoic because of the edema which is there. The volume increases and the body exceeds about 2.4 to 2.5 centimeters. There's anterior bowing of the pancreas, surface irregularity, and you will see edema surrounding the pancreas. There might be a heterogeneity of the pancreatic parenchyma. On CT, what you would see would be focal or diffuse pancreatic enlargement. There would be changes in density because of the edema. The margins become indistinct, and the fat around it shows you fat stranding. There is also associated retroperitoneal fat stranding. There may be liquefactive necrosis of the pancreatic parenchyma as well. CT ideally should be done 1 week after symptom onset to differentiate pancreatic hypoenhancement because of the edema from the necrosis which is there. And this is often multifocal. On MR, what you get is a loss of hyperintense signal. The pancreas is hyperintense because of the fat content, and this would suggest acute pancreatitis. A contrast-enhanced MR is equivalent to CT in the assessment of acute pancreatitis. And on diffusion, you will see a hyperintense signal of the involved parenchyma with loss of signal on ADC images. MR also helps you to differentiate, MR and CT help you to differentiate walled-off necrosis from pseudocysts. So on CT, what you see is a cystic lesion within or around the pancreas with an area of heterogeneous attenuation. MR is superior to CT in differentiating walled-off necrosis from pseudocyst because it has the ability to pick up the internal necrotic debris within the cystic lesion. Pseudocysts, of course, are fluid-filled masses. The wall is made up of inflammatory and fibrotic tissue. It doesn't have a true epithelial lining. That's why it's called as a pseudocyst. And they develop from a fluid collection following pancreatic injury circumscribed by a pseudocapsule. This was a patient who came to us with abdominal pain, and you can see the pancreas is bulky, it's heterogeneous, and you're seeing this thin hypoechoic rim surrounding the pancreas, which should make you think of acute pancreatitis. This patient also had a small amount of fluid which was there at the inferior margin of the spleen. And if you look at the movements of the left kidney, you will see that these are dampened as compared to the right kidney, and that would suggest that probably there is an acute pancreatitis which is causing this. This is a blown up image to show you the pancreas over here. This was a 55-year-old male who had epigastric pain with elevated serum lipase, 850 units per liter. And again, you can see that the pancreas is enlarged. You can see the pancreatic duct to some extent, and you're seeing this thin hypoechoic area surrounding the pancreas, again suggesting that there is edema. The same patient had a CT done, and you can see the fat surrounding the pancreas is showing this haziness or fat stranding over there. There is some amount of fluid or hypodensity seen in the region of the pancreatic head. There is pericholecystic fluid as well. And you can see that this is a case of acute pancreatitis. So along with that, you can see that anterior pararenal fascia over here also was thickened because of some amount of exudates over there. The patient had gallbladder calculi, so you should always look for calculi and always look at the CBD for associated CBD calculi. If the CBD is dilated, maybe that there are calculi over there. In this case, of course, MRCP would be better to pick up the calculi which are radiolucent. More images to show you the peripancreatic fat stranding, which you can see over here and over here as well in a case of acute pancreatitis. This was a 9-year-old boy with abdominal pain, and what we were seeing was an enlarged head of pancreas. That's the SMB, that's the SMA, and you're seeing that the pancreatic duct is dilated. This was the splenoportal axis, and that was another tubular structure parallel to the splenoportal axis, suggestive of the pancreatic duct, which was dilated. The CBD was also dilated, and we initially wondered whether this was a mass. And this turned out to be a case of focal pancreatitis. So this was something like a mass-forming pancreatitis. So it can mimic a pancreatitis, and you should be aware that this can occur and diagnose it for what it is. This was a 23-year-old female with abdominal pain since 4 days. Ultrasound showed a suspicious focal pancreatic lesion. Her pancreas, as you can see, is atrophic. You can barely see any pancreatic tissue. There are extensive areas of calcification here. You can't really see a duct dilatation. But what you are seeing is that the spleen is showing multiple focal areas within it. And she also had poorly visualized splenic vein near the hilum suggestive of splenic vein thrombosis. So this was a patient with pancreatitis who developed splenic vein thrombosis and developed splenic infarct subsequently. Known case of acute pancreatitis who underwent who was supposed to undergo cystogastrostomy. That's what you're seeing over here. That's a thick walled cystic lesion for which the patient was supposed to undergo cystogastrostomy. But what we saw when we did a CT was this well-defined hyperdense area with surrounding hypodensity, which on the arterial phase images showing it was lighting up and becoming hyperdense and showing you diffuse contrast enhancement. And this was a pseudoaneurysm, a splenic artery pseudoaneurysm, which had developed in this particular patient. So I think everybody is familiar with the modified CTSI scoring, which takes into account pancreatic inflammation, pancreatic necrosis, and extrapancreatic complications. And then it can grade the pancreatitis into mild, moderate, and severe, depending on what changes are available. I think most people are familiar with this. Groove pancreatitis is a rare form of chronic pancreatitis which affects the groove between the superior aspect of the pancreatic head and the duodenum. It's a diagnostic dilemma for radiologists, pathologists, and clinicians, and inability to distinguish it from primary duodenal, ampullary, or pancreatic malignancy often leads to surgery. And this is an image I have taken from an AJR article, which is showing you that there is some hypodensity here surrounding the pancreas. That's the duodenum there. And this is where you doubt whether this is malignancy or whether it's inflammation. And this turned out to be post-operatively a case of groove pancreatitis. Do I have time to cover solid tumors or should I stop here?
Maybe just briefly for 2 minutes, if you can shorten it,
Okay.
that would be nice.
Okay, so I'll just quickly go through the cases. So this was a 53-year-old female with abdominal pain since 8 months and weight loss. She had this enhancing lesion, brilliantly enhancing lesion on the arterial phase within the pancreatic head. And this was a case of neuroendocrine tumor of the pancreas. It's important where you're suspecting a neuroendocrine tumor of the pancreas to do an early pancreatic arterial phase and not the routine late arterial phase, or the pancreatic phase, which we use, because sometimes you might miss this. And this is another patient, and you can see this is a tiny neuroendocrine tumor of the pancreas. In the early arterial phase, you could pick it up, but if you go later, you may not pick it up at all. This patient also had tiny enhancing lesions, neuroendocrine tumors, which were there in the kidney as well. 60-year-old patient with pain in the abdomen, and what you're seeing here is this large mass which is there. It appears to be in continuity with the pancreatic duct. And we thought this was an IPMN, but it turned out to be a poorly differentiated pancreatic adenocarcinoma developing in a IPMN. So it's important when you're looking at pancreatic ductal adenocarcinomas that you follow the protocol, report the size of the tumor, the location, the ducts, the vessels, access resectability, arterial venous contact, and check metastasis and variant anatomy. This was a 11-year-old girl with abdominal pain, large mass in the region of the pancreatic head with some necrotic areas within it. These are CT images of the same patient. You can see it's a large solid tumor here, and this turned out to be a solid pseudopapillary tumor of the pancreas. And this was a known case of SPEN, and this patient on follow-up developed extensive liver metastasis. You can see the large mass here in the region of the body and the tail. It's a large solid mass there, and the extensive hepatic metastasis. So this patient has undergone malignant transformation. This was a CS stomach who had undergone radical gastrectomy. And later on, what we found was this well-defined hypointense lesion in the region of the pancreatic head, which was showing contrast enhancement, showing restricted diffusion. And this was either a metastasis to the pancreas from a CS stomach, or it was a primary pancreatic tumor. Trauma is the other thing, and you can see pancreatic fractures like this on CT. They are also beautifully seen on MR. MR is done basically to look at ductal anatomy and interruption of the duct. I won't cover pancreatic lesions, pancreatic cysts. So common pitfalls which are there are you can miss adenocarcinomas and neuroendocrine tumors if you don't protocolize your CT. If there are isoid attenuating tumors, there may be a duct cutoff and atrophy, which you must pick up. Autoimmune pancreatitis sometimes may mimic cancers. So In acute pancreatitis, CT should be done after 72 hours if there is no improvement. Evaluate for necrosis, collections, and vascular issues. MRCP for duct and biliary evaluation. CT, follow your pancreatic protocol. MRCP is important for looking at cysts, small tumors, and liver lesions. Endoscopic ultrasound, like I told you, for small lesions. Tissue sampling, do a dual phase CT. And if a neuroendocrine tumor is suspected, then an early arterial phase as well. And use a high iodine dose saline chaser. Thank you for a patient hearing.
Thank you so much, Dr. Joshi, for the very elaborate information on pancreatic imaging, starting from the, embryology and going through all the imaging modalities and also discussing the different findings. Thank you so much. At this
Thank
point, I
you.
would like to welcome Dr. Anil Arora. Sir, welcome to GAPU's program on pancreatic imaging.
Thank you.
May I now request you to introduce Dr. Avinash? And after his talk, I would like you to give your perspective on imaging of the pancreas from the view of treatment and surgery.
Yeah. Uh, I do not have the details. I had some confusion regarding the date. So I'll join you in the discussion. Can I just
Okay.
request Dr. Avinash to start with? Please read his biodata.
Yeah, I will just do that for you,
Yeah.
sir. Okay. So I would like to now introduce our second speaker, Dr. Avinash Kambadkon. He is Associate Professor of Radiology at Harvard Medical School. He is the founding director of the Center for Research and Innovation in Abdominal Imaging at MGH and serves as the medical director at the radiology department of Martha's Vineyard Hospital. He is currently the portfolio director for science and research at the Society of Abdominal Radiology. Dr. Kambadkon is on the board of directors of the Society for Advanced Body Imaging and is the vice chair of the GI subcommittee at RSNA. He has been honored with numerous awards, including the prestigious McGovern Award for Clinical Excellence at Massachusetts General Hospital in 2021. He has also received the Writing Service Award from the Society for Advanced Body Imaging in 2022. Dr. Kambadkun is an exemplary clinical radiologist recognized nationally and internationally as an expert in imaging of the pancreas, hepatobiliary system, and gastrointestinal tract. He is a renowned global leader in CT, dual energy CT in particular, and his work has led to improved implementation and optimization of these technologies in routine clinical practice. He has authored and co-authored over 275 peer-reviewed research publications and review articles and textbook chapters. Dr. Avinash, please.
Thank you. Can you guys hear me?
Yes.
Okay, thank you so much for the kind introduction, Dr. Vinita. I'm going to share my slide. Uh, can you guys see my slides?
Yes. I think
Perfect.
you have to do full screen.
Is it one-on-one now?
Yeah. That's good.
Perfect. Thank you so much. Again, thank you so much, Dr. Vinita, for the kind introduction. And I also want to thank Dr. Sahu and Gapio for the kind invitation and opportunity. So let's get started. So I'm going to speak on advanced imaging of pancreas, focusing on CT and AI. I must say, there was a terrific lecture by Dr. Joshi, a very comprehensive coverage of the fundamentals of imaging of the pancreas. I'm going to stop sharing myself so that we can focus on the slides. So these are my disclosures. I also have a couple of additional disclosures. I'm not an expert or a medical physicist. I have no experience in coding, but I love CT. So what I plan to do in the next 20 minutes is discuss the recent advances in CT in the realm of evaluation of the pancreas, focusing mostly on dual energy CT, artificial intelligence, and quantitative imaging. So I want to start by showing this image. This is the image, the picture of the first CT scanner, which was developed by Sir Godfrey Hounsfield, which was purchased for use in the United States. Now, interesting fact here is that we at MGH at Mass General Hospital were supposed to get this scanner, but the Mayo Clinic beat us to it. So now this scanner is in their museum in the CT Clinical Innovation Center, and this is my proud selfie moment way back in 2019 when I visited their CT Innovation Center. Now, ever since the introduction and installation of the first CT scanner, there have been tremendous technological advancements in CT scanner technology, ranging from introduction of spiral CT, multi-detector CT, dual energy CT, and now the most recent entrant being the photon counting CT. Even in the realm of dual energy CT, there has been incredible growth with development of multiple different types of spectral imaging platforms. These images in CT scanner technology have provided the impetus for other phenomenal innovations in CT, including various dose reduction strategies, novel software algorithms, development of volumetric and 3D techniques, introduction of newer contrast media with better safety profile, along with the development of the fascinating field of quantitative imaging and AI. Something else to keep in mind here is that if you look at the trends in the growth of CT over the past decade or so, CT has shown a consistent 10% increase annual growth in the past 5 years, and the annual market for CT systems was expected to grow to nearly $20 billion. Now, this growth in CT is secondary to increased utilization due to aging populations, development of newer therapies, uh, and better IT solutions and wider applications of the newer CT scanners like the dual energy CT scanners. Uh, One thing too important is that as with increasing utilization, the expectations on imaging have also changed. In this era of precision medicine, there is increasing emphasis on value-based care. That is care which is efficient, lowers cost, is patient-centered, and provides superior outcome. Now, uh, Dr. Joshi spoke about CT and its value in the pancreas. Now, single energy CT, which is by far the most commonly used technology around the world, is a terrific modality, provides a wide range of diagnosis, as Dr. Joshi said, in the pancreas, but it does have certain limitations. Limitations include inability to characterize small lesions, need for multiphasic or perfusion scan for determining response or tissue characterization, degradation of images from metal artifacts, which can complicate lesion assessment, a limited evaluation for local regional therapies, where a single phase may not be useful. We might need to acquire non-contrast scans, which is another limitation of single energy CT, which could lead to increased radiation dose. So now let's see the recent innovations in CT, that is dual energy CT, how it helps overcome some of these limitations. Now, dual energy CT by principle when it was introduced is a CT scanner which allows simultaneous scanning at high and low energy. Now, when a tissue is scanned at different energies, the different tissues behave differently. That is, a dual energy CT exploits the differential behavior of tissues at different energies to determine composition of tissues. So, for example, when you see the attenuation curves of different tissues at 80 and 140 kVp, which are the typical, kilovolt, which is used for scanning in patients who have undergo dual energy CT scanner, when you the dual energy CT algorithms look at the attenuation of different tissues at different energies and allows multi-material decomposition, that is generate images which are specific for iodine, fat, water, and calcium. So with a single dual energy CT acquisition, you're able to generate thousands of different types of image data sets as opposed to a single energy CT scanner. So for example, if you look at a typical protocol from a single energy CT scanner on your left hand side, from a typical single energy CT scanner, you have an axial acquisition and a coronal and sagittal reformations. But with dual energy CT scanner, depending on the technology, you get multiple different types of image data sets, like the 140 kVp image, which is equivalent to the single energy CT. You get mono energetic images, which allow better visualization of hyper and hypovascular lesions, and a set of virtual and enhanced and iodine images, which allow better tissue characterization. Now, these virtual and enhanced images are a surrogate for the true non-contrast CT images, which would typically require a separate acquisition with single energy CT. Now, when you have multiphasic exams, as Dr. Joshi mentioned for the pancreas, when you do a multiphasic pancreatic protocol CT, you can generate similar series for each phase. With that, let me quickly segue into the clinical applications and where dual energy CT uh, allows improved diagnosis. Here, I want to briefly talk about pancreatic cancer. Now, I won't go into detail about the demographics of pancreatic cancer. The incidence of pancreatic cancer is increasing, and in fact, now it is the third most common cause of cancer mortality in the United States. Dr. Joshi already spoke how difficult it is to image the pancreas. Now, if you look at the prognosis or the 5-year survival in patients with pancreatic cancer, the 5-year survival rate drops as the stage of pancreatic cancer increases. In fact, if you compare it to other GI cancers, pancreatic ductal adenocarcinoma has the worst prognosis with a 5-year survival rate nearly around 10%. Surgical resections offers curative treatment option. However, less than 25% of patients have resectable disease at the time of presentation. So now imaging plays an important role in the diagnosis and staging of pancreatic cancer. Now, if you compare CT and MRI, both CT and MRI perform comparably for diagnosis of pancreatic cancer and delineation of vascular involvement. Now, if you look at this meta-analysis, it found that both CT and MRI have similar accuracy. So if you look at the current NCCN guidelines, MDCT is preferred for evaluation of patients, diagnosis and staging of patients with pancreatic cancer. Dr. Joshi already spoke about a staging of pancreatic cancer and multiphasic pancreatic protocol CT. This is a typical pancreatic protocol CT, which is acquired at Mass General and most sites in the US with a pancreatic and a portal venous phase. Now, despite having a protocol intense acquisition in patients with pancreatic diseases, there are certain limitations to MDCT or single energy CT. That is, inability to identify acid-originating tumors in the pancreas, inability to characterize lymph nodes, detection of small liver metastasis, as well as detection of peritoneal disease. So let's see how dual energy CT helps here. Now, this is a typical pancreatic protocol dual energy CT acquisition at MGH. We have out of the 23 of our CT scanners, I think over 13 scanners are capable of doing dual energy CT scans. And you can see for every pancreatic protocol CT, multiple different types of images are required. The images which are important from a pancreatic perspective are the monoenergetic images here, which are acquired at 50 keV for pancreatic phase and 65 keV for the portal venous phase, and the iodine images. Now let's see the value of these image data sets in pancreatic ductal adenocarcinoma. So this is a patient, 63-year-old patient with abdominal pain. What you see here is a mass in the region of the head of the pancreas. When you look at the low KV monoenergetic images, several studies have demonstrated that low KV dual energy CT data sets improve detection of pancreatic mass during a pancreatic phase, with the most preferred images being in the 45 to 55 kV range. In addition, because dual energy CT allows acquisition of iodine images also demonstrate high SNR and CNR compared to monoenergetic and conventional 120 kVp images for both visualization of the primary tumor as well as enhancing reader confidence. Another conundrum commonly encountered in patients with pancreatic cancer is they often present from outside with the stents in place, either a plastic biliary stent or a metallic stent, which can sometimes the artifacts can make it hard to visualize lesions adjacent to the stents. Now, either iodine images or low KV monoenergetic images reduce the artifacts from, or high energy monoenergetic images reduce the artifacts from the stents and in fact allow better visualization of the pancreatic tumor, which is important to delineate the margins and also see their relationship to the surrounding vascular structures. Improved visualization of the tumor, both at low KV monoenergetic and iodine images, improve depiction of the tumor margins and relationship to surrounding structures. Another area where we have found dual energy CT to be really helpful is in those patients where you're suspecting peritoneal disease. Now, here is a patient with pancreatic cancer who had ascites and subtle thickening in the left upper quadrant, suspicious for pancreatic peritoneal metastasis. When you look at the iodine images and the color-coded iodine maps, you can see how these small peritoneal nodules light up. This was confirmed from PET CT, so just highlighting the value of dual energy CT data sets in identifying peritoneal disease. So low energy KV and iodine images acquired from dual energy CT acquisition in pancreatic cancer improves tumor conspicuity, allows better delineation of margins, allows enhanced visualization of the arteries and veins, and improved detection of tumors in presence of stains, leading to better tumor staging and treatment planning. In fact, if you look at this multi-institutional study we did across the US trying to identify what is the trend for imaging in patients in pancreatic cancer, we found that nearly 90% of the sites performed either a single energy CT or a multiphasic single energy CT or dual energy CT for evaluation of pancreatic cancer. MR was infrequently performed, so was a single phase portal venous phase CT. Dr. Joshi spoke about pancreatic neuroendocrine tumor. I won't go into details about the clinical features, but if you look at the accuracy of CT for detection and characterization of neuroendocrine tumors, the accuracy falls as the size of the lesion is smaller. Now, these are three examples from our clinical practice where you can see the regular conventional CT images, but when you look at the virtual monoenergetic and the iodine images, the hyper enhancing lesions in the pancreas become more evident. So if you look at the study from Lin et al., who did a retrospective study for insulinomas, they found that a combination of low KV monoenergetic and iodine image provided the highest sensitivity for detection of insulinomas compared to single energy CT. So these the dual energy CT data sets not only allow better qualitative evaluation of the pancreas, but also there is an emerging use of quantitative iodine metrics for evaluation of various diseases. Now, this volumetric iodine uptake, which is now being considered as a marker for tumor vascularity, has been used for assessing response in patients who are on anti-angiogenic treatment. In patients with pancreatic cancer, let's look at a conundrum often we encounter in patients who have had Whipple procedure or distal pancreatectomy for pancreatic cancer, where often it's hard, like in these two examples, to differentiate post-operative changes from a recurrent disease. Now, we performed a study at MGH where we looked at the ability of quantitative iodine markers to differentiate between enhancing solid tumors versus post-operative changes. And we found that the iodine images, quantitative iodine markers, allowed better characterization of recurrent disease at the treatment bed. Iodine quantification has also been found to improve characterization of early necrotizing pancreatitis or ischemic changes in patients with acute pancreatitis. Here's an interesting example from our clinical practice where we had a patient with chronic pancreatitis who came with acute abdominal pain. What you see here is there is a heterogeneous mass in the region of left upper quadrant. This was a single phase acquisition. The question was what's happening here. When you look at the iodine images, you clearly see a blush of contrast in the left upper quadrant at the site of this mass. And when you look at the virtual non-contrast images, all that turns out to be hematoma. In fact, this patient has had a pseudoaneurysm which was bleeding secondary to a complication from pancreatitis. This patient was then taken to the angio suite by our interventional colleagues and they found a pseudoaneurysm which was coil embolized. Now, in patients with chronic pancreatitis, one of the commonest challenges is differentiating chronic mass-forming pancreatitis from pancreatic ductal adenocarcinoma. Studies have shown that using iodine quantification and the slope of the spectral curve when you do a dual energy CT acquisition can allow differentiation of chronic mass-forming pancreatitis from pancreatic ductal adenocarcinoma. Another fascinating advantage of dual energy CT is because it allows you to generate multiple different types of image data sets. We did a hypothesis generating study where what we did was from a single portal venous phase acquisition, we generated a low KV monoenergetic image and tried to see if it could be a surrogate for the pancreatic phase. So essentially what we did was from a single portal venous phase, we generated a portal venous phase, pancreatic phase type of image. So a single portal venous phase image was developed as a twin pancreatic protocol CT. And what we found was it allowed accurate characterization of both pancreatic cysts and pancreatic ductal adenocarcinoma while allowing for substantial dose reduction. Now, this becomes especially important in patients who are on surveillance for pancreatic cysts. Now, there are advances in the realm of CT with the more recent introduction of photon counting CT. There's a lot of interest in this, and this is an image which was shared with me from my uh, friend Barry Dane from NYU, which shows improved characterization and identification of pancreatic masses in patients who undergo photon counting CT. This is a recent study which looked at the value of a photon counting CT and found that the monoenergetic images from photon counting CT allowed better characterization of pancreatic cancers. Now let's quickly segue into the role of quantitative imaging. Now there has been incredible growth in quantitative imaging in the past decade or so with increasing utilization of precision medicine. CT allows generation of numerous different types of parameters which allow quantitation, which can be used to enable gather anatomic, functional, and molecular information from diagnostic scans. Now, there are multiple different applications of quantitative imaging in the abdomen, including in the pancreas. Two areas I want to focus on. One is risk assessment. Now, you might have heard about body composition. There is a lot of interest in exploring the value of CT in quantification of compartmental distribution of fat and muscle within the body. There are multiple different parameters available. One such body composition metric is sarcopenia, which refers to decrease in the skeletal muscle quantity and quality. And while sarcopenia was initially considered as an age-related phenomenon, it is being increasingly realized that it can occur in younger patients, and in patients with a cancer it could be a prognostic indicator. For example, here are two examples in patients with pancreatic cancer. As you can see, in a patient with more muscle mass, the overall survival was much longer as opposed to a patient who are lower muscle mass. In fact, we looked at MGH, we looked at the value of body composition and sarcopenia, and looked at its association with life, quality of life, and depression. And what we found was in patients who had sarcopenia on imaging, they it was highly prevalent in patients with newly diagnosed incurable cancer, including pancreatic cancer, and there was higher association between worse quality of life and depression symptoms uh, in those patients who had sarcopenia, highlighting the importance of addressing the issue of sarcopenia early in the course of illness. The second element of quantitative imaging I want to focus on is radiomics. Now, radiomics refers to high throughput extraction and analysis of quantitative imaging features from medical images. Now, it's a huge field of radiomics. There are multiple different types of quantitative imaging parameters in radiomics which allow characterization of different diseases. From the perspective of pancreatic cancer, there's a lot of interest in using radiomics for better characterizing a response assessment in those patients who undergo neoadjuvant treatment. Now, one of the challenges with radiomics is it leads to generation of a large amount of data, and these data analysis can be challenging with the human brain. That's where AI comes into place. So when you use a combination of AI, which can handle a large amount of data, and radiomics, that can be used a very powerful tool for not only assessing response, but also characterizing disease and predicting patient outcome. I think I have 30 seconds more. I might use another more minute to just talk about AI. Um, I hope that's okay.
Sure, sure.
Yeah. So I want to talk about AI. And in AI, before dwelling into AI, let's talk about what artificial intelligence is. Now, artificial intelligence refers to creation of computer systems for performing tasks that generally require human intelligence. Now, machine learning is a subset of AI which involves training algorithms that perform tasks by learning from data-derived patterns and features. Deep learning is a class of machine learning which is characterized by utilization of deep neural networks with multiple layers of mathematical equations to complete the acquired task. Now, artificial intelligence has multiple different applications. If you look at the workflow in a patient who gets a CT, but from a pancreatic imaging perspective, I think there are four important areas. One is to improve image quality through image reconstruction. Second is to generate structured reports. Third is early cancer detection. And fourth is facilitate research with improved data. Now, image reconstruction in CT is very important to generate tomographic images from X-ray projection data. Now, there has been evolution of different types of CT image reconstruction algorithms, starting from filtered back projection to deep learning based reconstruction. And these innovations in the image reconstruction have kept up with the over the years the development of artificial intelligence based technologies, which have been supplemented by improved computational powers, training techniques, and modern algorithms. So now if you look at the most recent entrant into image reconstruction, it is the deep learning based image reconstruction algorithms, which allow higher image quality at lowest possible dose. These are some studies which we have performed where we looked at the ability of deep learning based technologies to improve image quality at lower dose. I'm going to quickly go on to this example here, which shows, deep learning based images, which actually improve image quality while, um, yeah, I'm not sure why the video is not running. It just shows improved image quality with deep learning based technologies. Now, quickly, I want to go on one area where we find the AI very helpful. That is in Dr. Joshi spoke about structured reporting, which is essentially important in patients with pancreatic cancer, where we have to report the relationship of the tumor to surrounding vasculature. This is a structured template which is used in our hospital. The template is quite complex. We did a study where we looked at the ability of large language models for generating these synoptic structured reports from the regular reports. And what we found was ChatGPT-4 was able to create near perfect PDAC synaptic reports from original reports, improving the workflow radiologists. Last section on pancreatic cancer screening, the rise, incidence and mortality of pancreatic ductal adenocarcinoma is rising. There's increasing interest in detecting pancreatic cancer before it manifests on imaging. And here are some research studies which have shown that radiomics-based machine learning models can detect PDAC from pancreatic cancer even before human interrogation capabilities. These are increasing data which is emerging on role of deep learning methods in early detection of pancreatic cancer. I know I rushed through the last slides a little bit, so basically I want to summarize. Advances in CT technology have added value in care of patients with pancreatic disorders. Dual energy CT enables improved lesion detection, characterization, tumor staging, and assessment of response. CT-based quantitative imaging tools are useful in screening and risk assessment, guiding treatment decisions and monitoring response. AI has the ability to allow enhanced value-based care through improved quality of images, supporting radiologist workflow and early detection of pancreatic cancer. Sorry, I think I went through a little fast, but thank you so much for your kind attention. There was a lot to cover.
Yeah. Yeah, thank you so much for the wonderful talk, Dr. Avinash. I mean, it has really been a learning for, I think, many of us about the quantitative imaging, then also knowing that AI can be helpful in actually improving the quality of imaging as well as will help in the early detection of pancreatic lesions. Thank you so much. May I now request Dr. Anil Arora to give a few words about the.
Yeah, thank you, ma'am, for giving me this. Am I audible?
Yes, yes, you are.
Okay. First of all, I am extremely thankful to both Dr. Joshi and Dr. Avinash for having given glimpses of what is happening today and the futuristic insights provided so well in a very nice presentation by Dr. Avinash. As a clinician who have been in the forefront of managing patients with acute pancreatitis, we have some of the issues where the CT does have limitations. Maybe we still do not have the type of the CT which Avinash was referring to in terms of dual energy CT. But our problems are that large number of the patients with severe necrotizing pancreatitis do have vascular and concomitant luminal complications in the form of erosion of these collections into the colon and as well as development of the pseudoaneurysm which present with bleeding. Now we have to do two CTs. First is a CCT to look at the degree of necrosis and their relationship to the surrounding viscous. And then more often than not, if you want to see a vessel, you have to do additional CT angio. So is it possible that with the futuristic CTs, you may have to not keep on repeating CTs, and once say dual energy CT or newer modification can give us answers whether these lesions are eroding into surrounding vessels or the luminal viscous. That is the first question I want to be addressed. And second is, why is it that everybody, especially in detection of the malignant tumors of the pancreas, MRI, if you look at the guidelines, scores over it. But as a practicing gastroenterologist, most of us are not tuned to looking at the MRI images. Most of us are very comfortable with CT. So why the discrepancy in the guidelines and the clinical conundrum?
Should I take that question or Dr. Joshi? I'm
No,
happy
you
to
can
answer.
you can go ahead, not a problem.
Okay. Thank you so much. Thank you for your question, Dr. Arora. Regarding your first question on whether we could combine, imaging and have a
Yeah.
single acquisition, absolutely. As Dr. Joshi already spoke about, if you do a multiphasic CT with arterial, pancreatic, and portal venous, you are able to capture, both vasculature as well as the parenchymal abnormalities. Now, I think what becomes key in these patients where you're suspecting luminal or vascular complications is the
Yeah.
timing of acquisition.
Yeah.
Especially even for characterization of necrotizing pancreatitis, as Dr. Joshi mentioned, we typically like to scan after 7 days or after 72 hours when you actually can identify the parenchymal changes. But what becomes important in patients where you suspect either luminal or vascular abnormalities is to have a high degree of suspicion when you're getting the CAT scan, is to get a multiphasic scan at the outset rather than getting a regular portal venous phase and then repeating a subsequent scan. And of course, dual energy CT is often helpful. As you see, even with a single phase, you can generate multiple different type of images to answer the question.
But
Now,
at the end
regarding
of the day, can I just interrupt? At the end of the day,
sure.
still, if you have to intervene in terms of the treatment of the patient, still you have to do another CT angio to localize the size and the location of the lesion before an IR guy intervenes. So based on CT alone, decision is usually not taken.
Can I
Yeah.
just submit over
Sure.
here that when you're running an arterial phase, it's like a CT, it is a CT angiography which you're getting. And you can reconstruct on it, you can MIP on it, you can do all kinds of things with that and give adequate amount of information. So I don't think you need to repeat a CT. Your intervention people can have a look at it, and that will be like a roadmap for them to go ahead and do whatever intervention they need to do.
Yeah, I
And
completely agree.
the IR guy says, "Oh, this was not CT angio. You are just there is a suspicion of an aneurysm. We would like to see it in toto, and then we go about it." So at the end of the day, most of the patient end up having a CT angio prior to a therapeutic intervention.
Yeah, and then it would depend on what was the nature of the first scan which was done. But as Dr. Joshi mentioned, if you do a pancreatic phase, you get pretty good arterial, depiction, and you can use that. Of course, if and you always have to look at risk benefit, and if the IR folks, and at least at the place where we work, a good quality pancreatic protocol CT can be a surrogate for looking at the vasculature. But if the IR folks do feel that they do find a CT angiography more valuable, I mean, yeah, you
Yeah.
could get that done. Yeah.
And second limitation is we see very large number of patients with severe necrotizing pancreatitis. They come with AKI at admission, or they tend to develop kidney injury with passage of time. And limitations of CT, both at presentation and later on, is there is no renal friendly dye. I like to ask Dr. Vinash, is there any progress to have a CT in a patient with significant renal injury?
A great question. Uh, the contrast agents have gotten much better. Now, we have isoosmolar contrast agents which can be administered in patients with, borderline renal dysfunction. In fact, I don't know how the practice is over there, but we usually do EGFR, and all patients who have EGFR over 30 can get ideated contrast. Of course, in those patients who have EGFR less than 30, that's a discussion you need to have with the your other providers, whether this patient needs some sort of hydration protocol to make sure there's no kidney injury. But if the patient really has bad kidneys and cannot get contrast, they can all get also always get a non-contrast CT and non-contrast MR. I'm sorry, a non-contrast MR is pretty good at especially T2 weighted images to allow you to get an idea of the distribution of necrosis within the pancreas in the peripancreatic region. It can show, as Dr. Joshi mentioned, it can show the pancreatic duct. If there's a pancreatic duct disruption, all those can be visualized. So in those patients who cannot get contrast, they can definitely get a non-contrast MRI.
And finally, a question which may not be directly related. There was a huge development in terms of very high quality virtual colonoscopy, which was CT based. Somehow it seems to have gone into oblivion. So any attempts and the type of progression you have, a type of advancement you have in CT, can that virtual colonoscopy ever replace the conventional colonoscopy, both in terms of diagnosis of established lesion and early screening?
Great question. I wouldn't say CT colonography has gone out of practice. In fact, it's making a comeback because recently CMS, I think, allowed recognized that CT colonography as an a technique which could be used for identification of colonic polyps. In fact, we do CT colonography routinely in our practice, and there are certain sites in the U.S. like Wisconsin, they perform both diagnostic and screening colonographies routinely. I think a lot has to be talked about because when you're doing a regular optical colonoscopy, there's an advantage of getting tissue which you cannot get with the CT colonography. But it is, I mean, used in practice. We do screening routinely in our practice. Of course, the volume is not as high as you would expect, but it's still performed, and it's still one of the options, especially in those patients who cannot get either an optical colonoscopy or prefer to not undergo sedation. It's a good technique.
In fact, even on a 128 slice CT, you get excellent colonography images, and it's really good for screening. We've had a couple of patients doctors who've come and asked for a colonoscopy to be done, a virtual colonoscopy. I think it's up to the gastroenterologist to refer the patients to us.
Yeah.
Only then, would they be aware of what we can do.
And finally, one of my friends was in MGH, Dr. Ram Chutani. I don't know whether you're aware of it. This is a guy who was my classmate in Delhi, and he introduced this concept of MRCP in India, which is practically replaced diagnostic ERCP. That is the reason I was tempted to ask whether virtual colonoscopy will one day replace the hard, tenuous and arduous colonoscopy, which is done left and right in all centers in US.
Yeah, I mean, I think that there is more interest now with this new CMS guidelines. I'm not most updated about what the United States Preventative Task Force recommendations are, but yeah, it's a possibility. But also you have to remember that there are other tests which are also becoming increasingly available for detecting colon cancer, like Cologuard, which is, I think, it's a so
both in
that
the
also
stool and
correct, so you have that as well.
okay, thank
Sorry,
you so much.
may I interrupt? I
Yeah.
think we are overshooting the time. So
Yeah.
in the interest of time, thank you so much, Dr. Anil Arora, Dr. Priscilla Joshi, and Dr. Avinash Kambadikon. It has really been a very enlightening evening. So I will now introduce Dr. Ashutosh Sahu for giving the vote of thanks. So Dr. Sahu is a fellow in emergency trauma and acute care radiology at the University of Toronto. He has pursued advanced training in neuroimaging at King's College London under the prestigious Commonwealth Scholarship. So he is soon to join Boston Children's Hospital Harvard Medical School for a fellowship in pediatric radiology. And following this, he will assume the role of assistant professor at the Department of Radiology at the University of Michigan Medical School, where he will be working in both pediatric and cardiothoracic imaging. And his clinical expertise is further strengthened by a robust research portfolio with several peer-reviewed publications, numerous conference presentations, and ongoing research projects. So, Dr. Sahul, please give the vote of thanks.
Thank you, Dr. Saran, for your kind introduction. And it has been a wonderful evening learning about the advancements in the pancreatic imaging. So I would like to extend my great heartfelt gratitude to both the speakers, Dr. Lieutenant Colonel Priscilla Joshi and Dr. Avinash Kamadkaran, for the precious time and enlightening us, the global audience, on what is really going on in the pancreatic imaging and how the field can advance further and what the future lies. And special thanks to our chairperson, Dr. Professor Anil Arora, for framing the session and emphasizing the clinical context so effectively, how like what the clinician needs and how from a clinical perspective, what and finally, to all the attendees, I would like to extend my gratitude for the time, for joining us across different time zones, and for the engagement and the thoughtful questions. And also, I would like to acknowledge the seamless backend support from the Doc Plexus. Our sincere thanks to Dr. Stephanie for coordinating with us, and Mr. Nitin for the IT support, for keeping everything running flawlessly. And finally, our appreciation to the GAPIO leadership and the organizing team behind the scenes for the meticulous planning. Thank you all for your time, and have a wonderful rest of the evening.
Actually, we do have a question for Dr. Priscilla, but is it okay if I send it to you, Doctor, later and get your reply and then send it back to the person who has asked it? Because we've already exceeded by 20 minutes. I think you
Question on
unmute.
PET CT and AI. So
Yeah,
I think
it is.
that was,
Yeah, have you
I
used
think
it?
that would be that AI probably is more directed towards Dr.
Okay,
Avinash.
so I will send it to both of you, whoever
All
can
right. Yeah, we
respond
can
to
do
it,
that.
and then
Yeah.
we can send it back to the person who has
Sure.
asked the question.
Sure.
Okay, so thank you very much. Thank you once again for being part of our GAPIO. I would really request you also to join our GAPIO platform. It's for all Indian doctors of Indian origin to be part of this program. So probably Jitendra will send you the link how to become a member for this program, the GAPIO. Okay, thank you and have a wonderful day in US and Canada, and good night in India.
Thank you.
And